Okay, thank you so much, Doug. So yes, I am a genetic counselor at the UC San Diego, and I've been helping families through predictive testing for Huntington's disease for about 13 years. So I'm happy to talk more about predictive testing, and I'm going to share my screen here, get some slides on there. In just a moment for everybody. I hope everyone is having a good Saturday so far. All right. I am sharing my screen. Fantastic. Okay. So what I would like to review today is just go over some of the basic genetics of Huntington's disease, of course, and then explore the predictive testing process. Because as you're thinking about your reproductive options, the first step might be thinking about testing for yourself or the at-risk parent, whether that's yourself or your spouse. So you might be thinking about predictive testing, although it's not required to go through in vitro fertilization. So we'll go through what motivates people in the predictive testing process and kind of what you should think about and what you should consider before going through that. And then, of course, with a focus on reproductive options today. So just from genetics real quick, we've got 20,000 genes in the cells of our body that tell our bodies how to grow and develop. And at the level of the DNA, as far as the genetic code, it's made up of letters, T's and A's and G's and C's. And so in the gene that causes or is associated with Huntington's disease, there is a 3-letter word or a CHE or CAG repeat that is repeated several times in a row. And when the DNA code is made correctly, it makes a protein called Huntington in the body, and that does what it should. But if the CAG repeat is abnormal, and we'll go over those numbers, then the protein can accumulate over time and cause symptoms of Huntington's disease. So a normal CAG repeat number is going to be 26 or less. Anything in that range is completely normal. There is an intermediate range of 27 to 35 where you are not at risk to develop Huntington's disease, but there may still be a small risk of expansion into the disease-causing range if you were to have children. And then the disease-causing range of 40 or more is the full penetrance, or a yes, we do expect you to develop Huntington's disease at some point. There is a reduced penetrance range of 36 to 39. Basically, in that range, some individuals have not developed symptoms or have developed them at an older age. I think everybody knows that it's dominant, meaning that we all have 2 copies of our genes, one from mom, one from dad. So someone who's affected typically has one normal copy or normal CAG repeat, and the other has that expansion. And it's just random 50-50 which one you would pass down to each of your children. And there's a rough correlation with the bigger that CAG repeat gets and the age of onset. Depends, the numbers might vary a little bit depending on what study you're looking at, but you can see if you have a CAG repeat size of 40, you might get symptoms in the late 50s, early 60s, versus if it goes up to 44, now we're thinking maybe symptoms in the 40s. So that is a phenomenon called anticipation, where the number of those CAG repeats can increase from one generation to the next. And then therefore, the age of onset could become earlier in successive generations. So usually the CAG repeat number from one generation to the next stays around the same ballpark, around the same number, probably plus or minus 1 or 2, but sometimes there could be a larger expansion. And that typically happens, and that's large would be like 5 or more. And that typically happens when a male is transmitting the condition, versus it tends to be more stable when it's the mother transmitting the condition. So this is just a pedigree showing an example of the grandparent, lived to 70. Maybe they weren't completely sure if he had the condition or not. And then we have someone, so boys are, I guess I should say, boys are squares, girls are circles in these pedigrees. So then his children, we've got an affected in red son over there who had symptoms at 55 with a CAG of 43. And then next generation down from him, now we have a CAG of 45 with symptoms at 40. versus if you go over to his affected daughter, has a 40 with symptoms in the 60s, and then that kind of remained 40 to the next generation with a similar age of onset as well. So it's helpful to have your parent or your affected relatives' genetic test results if possible. It's not required, but it kind of gives us a baseline as far as the number that we are starting with. And my colleague did this poster a few years ago. He also worked at the HDSA Center of Excellence at the time, just to kind of, this was data collected by survey to see, you know, why were people pursuing genetic testing? And their main reason was family planning. They were kind of evenly spread across the board and male and female, but if you separated it out by age, so the age 19 to 39 group, family planning was the #1 priority for pursuing genetic testing. And then in the age group of 40 to 75, it was really more to clarify their children's status. So maybe they didn't want to know for themselves or didn't have that option. And now their children are getting older, getting married, having kids of their own, and they wanted to clarify that. So I guess we are always thinking of our children. So at UC San Diego, we have a predictive testing program as part of the Center of Excellence. Our neurologist, our expert neurologist, is Dr. Jody Corey Bloom. And so I'm going to walk you through our process at UC San Diego. Please just keep in mind, I know not everyone is from my area here, that this could differ from institution. Other institutions, kind of the general nuts and bolts are similar, but they might have slightly different protocols. They may require different appointments with a neurologist or other individuals. So just keep in mind, this is kind of specific to UCSD and may vary by different institutions. So normally you call us. We want it to be initiated by you. We want this to be something you want to do in your decision. And then we would schedule a phone intake with the clinic coordinator just to go over basic information and the family history. And they would also mail you out a patient questionnaire with, again, some basic information and just some of those emotional questions to see kind of where you're at. That would get reviewed by the neurologist. I do not have a psychologist as part of our clinic, which I would love to, but basically that would be, if that's something that was needed, it would need to be an outside referral that we would need to look into. And then we would schedule the pre-test counseling, which I'll go in more detail about. And we do cheek swabs at my institution. And then there's always a session where we would go over the results together. So to go in more detail about the pre-test counseling and the genetic counseling, really it's just about an hour to explore your motivations, benefits, limitations, how will this impact you and your family. And it's really just an open conversation to help you be as prepared as possible, just so you can think of some things that maybe you didn't think about or have conversations or put plans in place. We do require a support person that's going through this with you. That could be a spouse or family member or friend. So what makes us unique is we offer confidential testing, and that's part of why our process is a little bit simplified, is we do offer it on a confidential basis, meaning your name is not on the result. It would be a random number. So it's more of cash pay confidential testing. So why we might not have some of the additional appointments involved as well. So that's pretty unique. That might not be offered at other institutions, depending on where you go. And we also do the testing in our own lab, which helps with that as well at UCSD. And we do telehealth. We were actually doing the pre-test counseling over telehealth before the pandemic. And then we would always make people come in person for the results. But now, of course, we've shifted to telehealth on both ends, which was challenging mostly for me at first. But I think there are a lot of benefits to getting that news in the comfort of your own home. And if you go through the genetic counseling, it's not required that you move forward with testing. It's okay to just talk about it and think through things. And it takes as much courage to decide that you're not ready to test, to decide that you are. And I might, make some suggestions or give you some homework. I'm not a barrier to testing at any means, but again, it's just to try and be prepared and make you think of some things. If you do need to establish with a therapist, maybe you could make an appointment before and after the results and then go from there. Or maybe there's a difficult conversation you need to have with a family member before getting results. And then we do the cheek swabs. If you're virtual, we mail them out, you mail them back. And it's the same, your DNA is the same in blood or the cheek cells. Your DNA is all the same, so it also works. And results are not disclosed until you actually have your results appointment with us. So you can change your mind, you can ask more questions until everybody's 100% ready to get those results together. And then, we can, of course, provide follow-up resources and support. We have a support group at our Center of Excellence in Research and Clinical Trials. So what might you think of going into that pre-test counseling? Obviously, everyone needs to make their own decision. So things I might ask you are, what does your support system look like? Again, is that a spouse, friends, family? Who are you going to talk to about this? Who are you going to ask for help if you're feeling down? Who's going to help you through this? Do you have strategies to cope with difficult emotions? Are there hobbies that you like to do? How have you dealt with difficult things in the past? Do you have a history of depression, anxiety, or suicidal thoughts? And the risk of suicide is kind of why all these protocols went into place. And again, we want you to be open and honest. It doesn't mean you can't get testing if you have any of this. It just means we need to be thoughtful and think about ways to support you. Again, a lot of people are already established with their own counselor or therapist or resources that they might need, but just to make sure, we've got a plan in place, the best way to support you. Is there a major stressor happening in your life right now, like a wedding, a new baby, a new job? Those might not be ideal times to go through genetic testing, but again, it's not my decision. It's for you just to kind of think through timing and strategies for how we're going to navigate these other events if they are happening. Are you going to get deployed? Are you moving? And another tough time tends to be if you had a family member who was just diagnosed, so it's all still a bit of a shock to everyone in the family, or has just recently passed away. Those are some kind of tough times, again, that you might want to think about, why now? But again, not a specific barrier to testing by any means. Who will you tell your results with? Are you going to talk to certain family members? Are you not going to tell certain family members? Are there any particularly difficult conversations that we can plan for or maybe have ahead of time? Some special examples might be, I've definitely had people where their parent was at risk and their parent was untested. So if you get a positive result, you're basically telling your parent you're positive. You should talk to them in advance about that and how they would feel, and do they want to know, and how are you going to have that conversation with them? Or don't have people texting you the day of your results session, so you can maybe have the information for yourself to process and then decide from there how you can share that information depending on your relationship with that person in a meaningful way. Have a family dinner or plan to be together, something like that. So just thinking through some of those difficult conversations. Anything else that you might change or do differently? We also always review insurance coverage. There are GINA laws. So that's the Genetic Information Non-Discrimination Act that was passed in 2008. And the law does protect you from discrimination by health insurers and employers based on genetic test results and genetic information. So you are protected there. But where that law doesn't extend is some of the more luxury insurances, like a life insurance policy or long-term care insurance. So we really do encourage you to look into that, or have your financial plans in place before testing. Again, we are trying to do this confidentially, but we might not be able to guarantee that confidentiality if then you're having, other medical appointments related to genetic testing. So just so you can answer the questions openly and honestly, we do recommend you look into that or have a plan in place beforehand. And of course, we always want to go over the reproductive options. So I just wanted to go over the full gamut of reproductive options really quickly. Of course, you could choose to adopt. You could choose to not have children. You could choose to do nothing and just conceive and have no testing. You could choose to have an egg or a sperm donor, depending on who was the at-risk parent. And then, of course, you could do pre-implantation genetic testing for monogenic disease, which is where you would go through the in vitro fertilization process, which Dr. Sue will go over much better than me after this. This is a very simplified picture over here, where basically eggs are retrieved from mom, mixed with sperm outside of the body, embryos start to grow. Once the embryos reach a certain stage, they can remove a few cells to do the genetic testing and ensure and implant the unaffected embryos back into mom. So again, this is very oversimplified at this point. It might require samples from other family members, et cetera. But that is an option. And there's also a form of it called non-disclosure PGT, where you as the at-risk parent may have the option to not necessarily know your status if that was very important to you, but still go through the in vitro fertilization process to make sure you're not passing it down. And then this doesn't come up as often, but there is also prenatal diagnosis. So you can test an ongoing pregnancy for Huntington's disease with a genetic test that would require either taking tissue from the placenta or chorionic villus sampling or an amniocentesis in the pregnancy. That is where they insert a needle through mom's stomach and take out fluid from around the baby, which has skin cells floating in it. So with both of those procedures, they can get cells from the pregnancy to do the genetic testing in the lab. Both of those procedures have small risks of miscarriage, but at this point you're already pregnant. So really this is reserved for individuals that would terminate the pregnancy based on a positive result, because we don't want to test just for information only, just like we would not want to test a child for this condition that is adult onset, because we would want them to become an adult. We don't test individuals under 18. We would want them to grow up and go through their own counseling and make the decision for themselves. And just really briefly, some people ask me about, does HD skip a generation? And of course the answer is no. If you have that expansion, it's the 50-50 to pass it down, just with that caveat of the number could differ or change slightly, but it's still the 50-50. And then if you have two normal copies, then you can't possibly pass it down under 26, of course. So if you have an 18 and a 20, you can either pass down 18 or 20. Both of those are completely normal. Again, with that small exception of the intermediate range, where there may be a risk for it to jump from intermediate to the disease-causing range, although the chance of that is overall still really low. And you can inherit the condition equally from either mom or dad, whoever has it. It's just, again, that expansion, the bigger jumps in the expansions tend to happen when it's inherited from a father. Again, not always, most likely around the same number, but we can see those bigger jumps with paternal transmission. And that is my little walkthrough through the process. I wanted to leave some time if there were some burning questions for me at this point. There's a nice YouTube video by a genetic counselor up in the Bay Area by Kaiser on predictive testing. You can find a genetic counselor in your area at the National Society of Genetic Counselors website. That is my email if you need me for any reason. And obviously the HDSA has lots of resources, and the UCSD does have our Center of Excellence. That is our website with more information about predictive testing, as well as research and clinical trials. So thank you.
Good job, Lauren. Thank you. If anyone does have any questions right now, we do have a few minutes for them to be asked.
I have a question. Lauren, I've always been really curious about people who get the testing but don't know their own status. How exactly does that work?
You mean the PGT?
Yeah.
Yeah. So my understanding is that it probably differs between the fertility center that you're working with. However, stop sharing. However, they may do direct testing of the embryos. There we go. And Dr. Sue can correct me in her talk if I say something wrong. But basically, they can either do direct testing of the embryos and maybe also do chromosomal screening, so PGT for aneuploidy, so screening for Down syndrome, and then they don't tell you exactly why they're not using that embryo, or that embryo wasn't suitable, so you wouldn't necessarily know if it was Huntington's or Down syndrome or other issue going on. The other thing I've heard of is that they can do linkage. So if you are the at-risk parent and your dad had it, they can figure out by looking at genetic markers which copy of the gene came from your dad, and they just exclude that one.
Gotcha. That sounds less anxiety producing, the second option, you know, because I can imagine being a person who didn't know their status and then being told that their embryos weren't viable, and then that causing you anxiety and wondering why, you know?
Yeah, but the one, you know, with the parents, it might require that those people are available for samples to figure out the genetic markers.
Does anyone else have any questions to ask Lauren? Okay.
This is Nikki, and I actually think I have a question for Lauren.
Okay.
So Lauren, I have a question. Have you ever had a scenario where an individual comes in and they have inherited the gene from both their mother and their father, where both their parents are carry the HD gene? And then what does that mean for that individual? Is the PGT-M genetic testing, is that even an option for them to be able to eliminate that gene if they carry, if you know their CAG is within that range from both parents?
So I have never had that happen. And if, in theory, if you had both copies of the gene abnormal, then there would be 100% chance of transmission. So then no.
And I only asked that question because I had an applicant ask that.
Okay.
Yeah. Okay. Perfect. Thank you.
Okay, Dr. Sue will be our next speaker. Dr. Sue, do you want to share your screen? Dr. Sue's topic will be IVF process, and I'll give you a quick introduction. Dr. Sue is a professor of Obstetrics, Gynecology, and Reproductive Sciences at UC San Diego. She directs the Reproductive Survivor Program at UC San Diego Health and provides fertility preservation, in vitro fertilization, and range of infertility treatment options at the Reproductive Partners Fertility Center in San Diego. So, Dr. Sue, thank you again for participating, and the show is turned over to you.
Yeah, thank you so much for the invitation, and really happy to, hopefully chime in on some of the questions that have already been raised. But I think my main goal is to talk through the nitty-gritty of IVF, and then the process of PGT when it is clinically applied in our lab. So I think Lauren already got to this, which is there are many reproductive choices in people with Huntington disease or potential of carrying a risk gene. And that is, if you are to use autologous gametes, then you can attempt unassisted. There is prenatal testing. Lauren talked about donor oocytes, donor sperm, embryo donation, adoption, and choosing to live child-free. So the overall goals of today's talk is to overview the IVF process and overview PGT. And this is Louise Brown. This is our very first IVF baby in the world, and she was born in 1978. So it's been decades for the development of safe and effective means of assisted reproductive technology, and I think we keep improving. I think IVF, to understand that, it's really good to be able to understand unassisted conception. And on the left, it really speaks to, in a reproductive age female, what happens when you try to conceive unassisted. In a given month, that female develops one oocyte, and then that oocyte ovulates. In the fallopian tube, the oocyte is fertilized, then the embryo is developed, rolls into the uterus, and then implants in the uterus. So to me, if you understand this, then IVF is just kind of a souped up version of this, where instead of developing one oocyte, we use supraphysiologic or more than your normal amounts of brain hormones to your ovaries to stimulate the ovaries to grow multiple oocytes of that month. Then instead of ovulating from the ovary and then having that egg get picked up by the fallopian tube, there is a 30-minute surgery called an egg retrieval, where a woman is asleep, and once that they are asleep, there is a needle that goes along the ultrasound in the vagina to go into the ovary to retrieve those eggs. So the eggs are kind of leaving the ovary very much like ovulation. In unassisted conceptions, fertilization happens in the fallopian tube, whereas in IVF, it happens through putting 50,000 good sperm around an egg, or a procedure called ICSI, intracytoplasmic sperm injection, in which a good-looking sperm swimming forward is chosen and then injected 1 sperm per egg. Then in unassisted conceptions, embryos develop in the fallopian tube and then roll into the uterus. And in IVF, these embryos are cultured and then either frozen or transferred. And in this situation of using PGT-M, they are frozen. Then in a subsequent month, once PGT-M has already been undertaken and you've selected which is the best embryo to transfer, then this embryo is placed back into the uterus, similar to how an embryo rolls into the uterus and then implants there. So as an overview of what I've just said, here you have the ovary and fallopian tube where the egg sort of leaves and usually travels into the fallopian tube, except now we are using a needle to come into the ovary to retrieve eggs. This is called an egg aspiration. These eggs are placed here inside the bubble, inside a petri dish, and sperm added as well. These eggs and embryos are then incubated for really about 5 to 7 days before they're frozen, and then in the future placed back into the uterus through this catheter. So normal ovarian physiology is actually really important to understand, and if you've ever been our patients or our trainees, you know that we talk about how a good ovary is like a chocolate chip cookie. So this is, and you know that if you want a good chocolate chip cookie, it has a lot of chocolate chips. So here's why. When we're born, females, we have really at birth about 1 to 2 million eggs. We don't make new eggs. People are have debated that over a lot of reproductive biology, but to this day we think we don't make new eggs. So, but how is it that if you start life with 1 to 2 million eggs, and at puberty we have about 400,000, but every month you ovulate 1 egg. That means that you spend about 400 to 500 eggs as you ovulate. This is if you have no birth control pills and things like this. So if you ovulate 400 to 500 eggs, then what the heck happens to the other million? And so on the right is an example of a vaginal ultrasound, and this is the vagina and this is the ovary, and you can see, or my attempt to think that this looks like a chocolate chip cookie. Each of these chocolate chips is something called an ovarian follicle. So it is that in a young person, so suppose you're 25 years old, I think you have 100 to 200,000 eggs remaining, and we're going to call that the underlying ovarian reserve. Proportional to that underlying ovarian reserve, a few eggs start to grow every day of our reproductive life. In that cohort of starting to grow eggs, I'm going to call that the functional ovarian pool. And that you can measure in a couple of ways. One, you can measure that by ultrasound, because essentially in each of these follicles is a starting to grow egg in the functional ovarian pool. The second is that there is a hormone called anti-Mullerian hormone, AMH, and that's also secreted by these starting to grow eggs. And finally, some folks who have undergone fertility treatments know that frequently there is a hormone measure called FSH, follicle stimulating hormone. And that's a hormone from our brain that tells our brain every month to go grow one egg. So conceptually, the larger the underlying ovarian reserve, the more starting to grow eggs, or the larger that functional ovarian pool is. And therefore, you should see more ovarian follicles or more chocolate chips on a cookie. You should have higher AMH levels. And then because your brain doesn't have to work all that hard if there are a lot of eggs around, then you should see lower FSH levels. The reason why these measures of ovarian reserve matter when you are thinking about fertility treatments is because it is only this functional pool of eggs that we know how to move with our fertility drugs. So the larger the pool, the more likely you are to yield a reasonable number of oocytes to go through the process of fertilization, embryo development, and pre-implantation genetic testing. So if you sort of understand normal physiology, that in a given month, if you start off with 15 to 20 follicles, which is here on the left, so again, here's the ovary, and these are the potential follicles, our brain only makes a little bit of FSH, so that if I start off the month with 20 possible eggs, I'm gonna ovulate only one, so one of the 20 will be ovulated, but the other 19 kind of die off. That's how we lost the million, not because we ovulated all million eggs, but because so many eggs undergo attrition every month. And they undergo attrition simply because the process of ovulation is rate limited by how much FSH hormone our brain makes. So when smart reproductive biologists figured that out, essentially we were able to make drugs that are FSH and LH, so the same hormones that our brain makes, but now we can give more of it. And by giving more of it, you end up rescuing some of the 19 other eggs that that female was going to throw away in the month. So on the left is at the beginning of the month. So suppose this person started off with 15 to 20 follicles. On her own, we would have only seen one follicle continue to grow, and the little egg in here would be the one that ovulates. But instead, if we apply daily injections of FSH and LH, then you can rescue some of those other 19. So now the ovary looks like it has 1, 2, 3, 4, 5, 6, at least 6 growing follicles, meaning 6 eggs. And the reason why you have to grow is because here on the left at this stage, when they're early, the eggs are not mature. And if you don't have a mature egg, it can't be fertilized. So we have to go through this process of ovarian stimulation. And this on average is about 2 weeks to grow the follicles. And then that follicle can nurture the egg inside to become mature. These injections are generally administered by patients or partners or family members, and they are subcutaneous, so teeny tiny needles like what diabetics give themselves insulin with. It goes into the skin of our belly each night. During those 2 weeks, there are also frequent monitoring appointments at your fertility center, and generally what's being monitored are estrogen levels and the size of these follicles by ultrasound. So I would say in general, there are 5 or 6 pretty frequent visits. The reason for that is because the dose of this medication, it's adjustable. So if you have a ton of follicles, we don't use much drug, whereas if you don't have a lot of follicles, you have to use more, but you titrate the medicines along the way in response to your parameters. And that's why the frequent monitoring. So these 2 weeks of at-home injections coming into the clinic to undergo this monitoring culminates in an egg retrieval. So what you're seeing here is this is a side view of a woman's pelvis where her head is in this direction and her legs are in this direction. This is the vagina, and this is the ultrasound vaginally with which we have been watching the eggs grow. And what you're seeing is a very small needle that goes through the vagina into the ovary to suck the fluid of each follicle out. And when you suck the fluid out, the little egg that's inside loosens from the wall and gets picked up along the fluid into this tube, into a basically a container that comes into the embryology lab. Another way of looking at it is on the top right, you see this ultrasound image. In the prior slide, I had shown you this is that ovary with multiple, large follicles. And so hopefully there's one egg in each of these that's ready. And you'll see through the vagina, this is my needle, or this is a needle, this is not my needle, a needle that goes through the vagina into the follicle. And as we suck the fluid out, then we hope that mature eggs will come out with. And just one last view. So conceptually, if this is the cervix, this is the vagina, here's the ultrasound, then the needle goes through the vagina right into the ovary to suck the eggs out. Frequently, patients will ask, does the needle kind of go up into the uterus, go through the fallopian tube? And actually, that's really hard. This is much easier. So the gauge of the needle is kind of like a larger IV needle, so it's not too big. People are put under sedation, so completely asleep during this process. It takes about half an hour. And so what happens next is that in the embryology lab, embryologists are looking under the microscope for good eggs. And so what a good egg looks like is this. This is the egg itself. This is the shell around the egg. And all of these are the support cells that have helped to grow that egg over really the past, since you were born, but primarily over the prior 2 weeks. You need a mature egg, as I had said, in order to undergo fertilization, and that's why the requirement still for those 2 weeks of stimulation. And there are a couple of ways to fertilize. On the left is the idea of co-incubation or insemination, where there are a ton of sperm introduced around each egg, and you let the best sperm win. And on the right is ICSI, where this is a holding pipette. This is the oocyte, and there's a needle that's introducing one swimming forward, morphologically normal sperm into that egg. And so that is done on the day of the egg retrieval. We're going to call that day 0. And this is what's going to happen over the next 7 days. So on day 1, what we're looking for is a fertilized egg. And this looks like it has mom and dad's DNA, or the donor sperm and then the donor egg's DNA. Then on day 3, 2 days later, you want to see embryos that are beautiful like this, really lots of cells inside. These are called cleavage embryos that are kind of even, and this remains the shell. Between days 5 to 7, we grow embryos into a stage called the blastocyst. And I think these are good examples of how variable embryos can look, where essentially where you started was with 1 egg and 1 sperm. Each carries its own DNA. And so all of the cells of this embryo really carries the DNA to reflect that of that 1 egg and that 1 sperm. By this blastocyst stage, the embryo has really between 50 to 100 cells, and they've differentiated into a clump of cells that will become us. So this is called the inner cell mass. And then all the cells on the outside that will become the placenta. So if we reason that all cells come from the same 1 egg and 1 sperm, it is possible to biopsy 3 to 5 cells from the part that will become the placenta, freeze those cells, send those cells to a PGT lab, for then the lab to undertake analysis of that DNA. And specifically what happens is that the DNA of those cells are amplified across the whole genome. And then they are then looking for different types of genetic testing that I'm going to talk about in the next few slides. So whatever the genetic testing results of those cells from the trophectoderm or the placenta is, you assume that that represents the whole embryo. Genetic testing takes time to come back. And therefore, at this stage, embryos are then frozen until we know what the genetic testing results are. And this is an example of how we biopsy embryos. So this is that same holding pipette, and these embryos are about 1 to 2 millimeters in diameter. This is that blastocyst embryo, where here, this is that clump of cells that becomes the fetus, and then these are the cells of the trophectoderm. So taking care not to directly impact the cells that become the fetus, the cells that are being biopsied on this side are really being taken away, like in the pull away from the inner cell mass. There are 2 types of genetic testing that can be done. One is called PGT-M, which I think is of the particular interest here today. And then the second is aneuploidy screening of these blastocyst embryos, which remains really controversial, and I'm happy to talk about why. So this is a lot of numbers, but I want to take some time to go through it so we can think through what is normal attrition. So if you start off with a sperm and an egg here, then on average, 70% of eggs will fertilize. On average of fertilized eggs, half will make it to the blastocyst stage. And on average, for someone who is not the case that was brought up earlier, but for an individual who is a carrier of the HD gene expansion, then half of their eggs or half of their sperm would also have would also have the mutated gene, while the other half would not, right? And so then by inference, then half of these embryos would have been derived from an egg or a sperm that is an HD carrier and the other is not. So therefore at this stage, you would have half of the embryos remaining. When we freeze and thaw embryos, 95% will survive the freeze thaw, which is excellent because freezing technology is better than ever. And then the live birth rate per transfer is dependent on the age. So then let's do some math on Saturday morning. If you start off with 15 eggs and 70% fertilizes, this is 10 eggs on average. And then on average, that means you get to 5 blastocyst embryos. If you test for PGT-M, then that leaves you 2 to 3 blastocysts. And because really all embryos that are frozen pretty much survive the thaw, that gives you 2 to 3 chances each time putting one embryo back, each transfer. So then let me show you the overall national rates for live birth per transfer, but then tell you also that this varies a lot by fertility center. So doing homework is really important. So Lauren talked about homework, so this is your homework if you're thinking about IVF. So 90% of IVF labs in this country publicly report our data to an organization called SART. It's a Society of Assisted Reproductive Technology. And because there's sperm aging as well, but there is a good amount of oocyte aging, the success rate, meaning do you have a live birth, varies by the age of the eggs, and this is how the data are posted. So cumulatively in 2019, this is the number of patients across the US in one of these SART reporting clinics that underwent IVF. So this is not for PGT-M only, it's really for all comers, and the vast majority of people who go through IVF have infertility. So if you are here in the less than 35 age group versus the other age groups are 35 to 37, 38 to 40, 41 to 42, and relatively few over 42 years old, the chance that you will walk away from an IVF cycle with a singleton birth is about 64% in this group, and then it decreases as we go. And I think a part of the reason why this decreases as we go is simply because both the number of follicles, the ovarian reserve that a woman has, declines with age, right? Because we saw that attrition, as we get older, there are fewer underlying reserve, therefore fewer functional ovarian reserve, and fewer eggs that you can get in a cycle. In the prior slide, I also showed that once you get eggs, there's a lot of attrition. So if you start off with a smaller number of possible eggs, then you will have fewer transferable embryos. And then finally, in the next slides, we're going to go through PGT-A, which is aneuploidy testing. And we know that the proportion of embryos that don't have the right number of chromosomes, that proportion increases as we age. So I think these are all contributory factors as to why singleton births per patient really declines as we age. Oh, the other point here is that it remains that we still have an unreasonably high number of twin pregnancies. This is so much better than when IVF first started, but it is super important to think about when you have multiple embryos to transfer. I know patients really go through a lot to go through IVF, but to try to transfer one embryo at a time, because twins bias a lot more perinatal risks, and that's not needed in this age when embryos can be frozen for a long time and have the same reproductive capacity. So potentially for baby number 2 in the future rather than transferring 2 together. So this remains a hot debate in ART. This is what we know. Parents are 46 chromosomes, but that means that the egg and the sperm start off each with 46 chromosomes to begin with. But in order to come back and combine and become potentially another human being, then that egg has to get rid of 23 chromosomes, and that sperm has to get rid of 23 chromosomes. And they each make a lot of mistakes. And you can't know that ahead of IVF, because if you tested that one sperm or you tested that one egg, you would not have a gamete to use. So what we know is that when you put them together and at the blastocyst embryo stage and you biopsy those 3 to 5 cells for genetic testing, it is also possible to look for how many chromosomes that there are. And I guess I think about this, and I don't know if this anecdote works. Sometimes it does and sometimes it doesn't, so I'll try here. if you think about each embryo or each of us as being a 46 chapter book, sort of equivalent of 46 chromosomes, this type of testing, it really allows you to say, are there 46 chapters in this book, or do you have an extra chapter, extra half chapter? But it's not looking at the spelling mistakes of individual words in the book. So it's kind of a really high level look at, do you have the right number of chromosomes? And so here you can see that the proportion aneuploid, meaning not 46 chromosomes, it could be 47, 48, it could be on all kinds of different chromosomes, because in the process of trying to get rid of half of the chromosomes, errors can happen all along chromosomes 1 to 22, as well as the sex chromosomes. This proportion increases, so that here by age 41, 42, we think that 80% of those blastocyst embryos are not chromosomally normal. So once we figured out that it is possible to measure the number of chromosomes in a very small number of cells, then it became, well, duh, why wouldn't you? Because if the chromosome number is not normal, the vast majority of the time, and you put the embryo in, you are not pregnant. But it's controversial because the clinical data have not supported a lot of help. And so I would say the summary answer is that for the youngest of patients in that age less than 35 group, there are a couple of clinical trials to show that if you have done genetic testing for aneuploidy of those embryos, you increase the live birth rate by about 10%. I think that's a reasonable estimate. So another way of thinking about this is that I usually counsel my less than 35 patients that in our lab, if I put one embryo back untested, younger than 35, the likelihood that I'm going to have a live birth is about 60-65%. So high already. And so if you've done genetic testing for aneuploidy, now it goes up to 70-75%. Is that 10% meaningful? And so it's not a big jump from 60% to 100%. So that's one reason why this is controversial. The second reason is because the technique of PGT, we think, does not harm the biopsy, does not harm the embryo, but there is variability in how good the hands are of the embryologists who do this biopsy. There's variability in how good the genetic testing lab is in calling abnormals versus normals, so that any medical test has the possibility of being wrong. And so the wrong impact of PGT-A has two types. One is a false positive. And so that's when I'm going to tell you, this embryo is not normal. Your action would be, you're not going to transfer this embryo. But if I'm wrong and this embryo could have been a totally healthy baby, then we would have thrown away an embryo that could have otherwise been a baby. Reasonable data show that this on average is low. It's probably about 2 to 5%. But if you're my 40-year-old patient and you have one embryo to use, it becomes a very shared decision making among us as to whether you want to take that 2 to 5% chance of a false positive. The other way I feel is less impactful, which is false negative, that we call an embryo normal when in fact it is not. Because if you become pregnant with an embryo that has a false negative finding, I think the vast majority of the time, abnormal embryos actually don't continue. It's self-selection, natural selection, and sometimes people have a miscarriage, right? Because the rate of miscarriage in the general population when pregnant is about 25%, and that's a part of that. And then there's also prenatal testing. So I think that's less consequential than the idea of if the number of embryos is few, particularly because I just even had shown you that from a good 15 eggs, we're down to 2 to 3 after PGT-M for HD. And then so do you or do you not do aneuploidy testing if you have this risk of false positives? So I think having multiple times to talk about this with our patients from the standpoint of patients' goals and also kind of the science or the data that we know, I think it's some of the richest conversations that we have as a reproductive endocrinologist. The other question that sometimes patients will ask is, should we be freezing eggs? I think this comes a lot from my oncofertility background, but if you have young individuals, for example, families affected by BRCA mutations that cause higher risks of breast and ovarian cancer, we often see young patients who know that they want to do PGT-M down the line. So if you know that you have more eggs when you're younger and better quality eggs, and you know you're destined to do PGT-M, then what is the upside or the downside of freezing eggs in your 20s in order to use those eggs when you meet your partner, when you're ready to grow your family. So this is the kind of the take-home message of egg freezing. I had shown you the attrition here on the right for if you fertilize up front. On the right, I'm now showing you the difference if you freeze eggs. So if you start off with eggs on top and you freeze, someday you're going to want to thaw. So that's what I'm demonstrating here. You got to thaw the eggs and then fertilize. The key thing is that right now when we thaw eggs, we have on average about 80% survival. So that instead of, say, on the left side having 20 eggs to begin with to fertilize right away, on the right you start with 16 eggs. So then ultimately, if you go down this cascade, you really have, for starting with 20 eggs, 1 to 2 fewer chances of trying. But then you also have younger eggs, potentially more eggs. So this is something to think about for individuals who know what they want is to do PGTM in the future. We've talked a lot about how do we use IVF and PGT as ways of selecting embryos. And so let's talk about prepping the uterus. So this is the vaginal ultrasound again, and this is the uterus, and this is the lining of the uterus. So whether through a natural cycle, so that in that month that patient is ovulating on her own, and the hormones that her ovary makes the lining of the uterus ready for implantation. When after ovulation that happens, then we can, at the right time, use a catheter to put the embryo back into the uterus in a natural cycle frozen embryo transfer. It is also possible to do a medicated frozen embryo transfer where women will use estrogen pills or estrogen stickers on their belly to prepare the lining of the uterus, and then do vaginal progesterone or more likely intramuscular progesterone shots in their buttocks daily to mimic having ovulated, and again putting the embryo back at the right timing. And this is again that once you put one embryo back, the chance of having a live birth varies by age. So I think my take-home messages are IVF, I think, is a safe and effective intervention. Good long-term health data, but really up until kind of the late teens, right? To follow IVF babies out for decades and decades when Louise Brown herself is really in her 40s. That's not there yet, but we have fairly good data into the late teenage years that are, I think, largely reassuring. If I had my choice of choices and didn't have, I think having unassisted conceptions is sort of, in some ways, sometimes the safest that we can make pregnancies, but more than ever in the area of reproductive science, reproductive medicine, trying to study normal physiology allows us to adapt IVF and other types of assisted reproductive technology to be as close to physiology as we can. I think I talked a lot about being cognizant that there's attrition of oocytes, embryos, that is just normal and it's age dependent. And then some speculations about what the future holds. I think the two things that come in mind right this moment are the idea of CRISPR, which is can you in an embryo make gene editing against a HD mutation so that you can use more of the embryos. That is the stuff of science fiction and remains with many, many ethical and safety issues. So this is not ready for prime time. The second, thinking about what the future holds, is that, given the threat to reproductive choice across the US, I think that, and we are lucky to be in California, which is considered a sanctuary state for abortion, that in this current age, with laws being passed across the country, including the law in Oklahoma this week, I think that thinking about IVF and thinking about how state laws might define when and what is life, that will impact the ability to do IVF with genetic testing, I think, in variable states. So that is also something that I feel is sort of, no matter where you are on the political spectrum, but if you are thinking about IVF, this is something that you should be aware of. So I'm going to end there, and hopefully I also have a few minutes to answer questions. Thank you very much.
If anyone has any questions, go ahead and unmute yourself and ask them.
I don't have any questions, but I just want to say that was a really fascinating presentation. I've never had it explained to me like that before, and I did not realize just how challenging it is to go from egg to embryo to implantation to live birth until I just watched that. And I want to thank you for making that so easy to understand.
I didn't give credit to where credit belongs. So Omar Messina is our second-year OBGYN resident, and the nice pictorial of the attrition is something that we literally worked on a couple of weeks ago. So I will give him feedback.
Yeah, that was really
good to understand.
I actually just had a friend who went through this as a surrogate. So it wasn't for Huntington's, but it was another woman who had some, she had to have her ovaries removed. And when they harvested, they weren't able to get very many eggs out of her, and they had 3 frozen embryos. And she was able to successfully bring the first implantation to live birth. And they kept telling me how much of a miracle it was that this happened. And now I see why. I almost cried actually watching your explanation of that.
Excellent presentation. Thank you. And to the viewers, if anyone has any questions that they think of later on, email them to me. My email is on HDSA San Diego chapter's website. And I'll get that information to the speakers, and we'll get them answered. If no one else, does anyone else have any questions?
I was just going to clarify the question Nikki asked me earlier. What I said was true, that if you have 2 abnormal copies of the gene, you would have 100% transmission, so wouldn't be eligible. But if you had both parents affected and you didn't know your genetic status yet, the chance of that having 2 abnormal copies would be 25%, or 1 in 4. Does that make sense? So it doesn't guarantee that if both parents are affected that you're going to get it. I just wanted to clarify that.
Yes, that does. And I'm going to have to circle back to the couple who inquired to me. I'm pretty certain that he knows his HD status, and that he knows that that he did inherit the gene from both parents.
Both.
They wanted to apply, but asked if it was possible. And even with all of my knowledge, I had not had that question before. So I thought it was the perfect platform to clarify. So thank you.
Yeah, sorry.
If I can sort of jump on that, sort of theoretically thinking about this, right, that the number of CAG repeats may vary by mom or dad, or by what that individual now has inherited. And so what can you actually see in PGTM? So the genetic testing labs will build probes for your family, because it is both trying to PCR up the number of CAG repeats, but it's also the idea of carrier mapping, right? Seeing the markers around the gene to see whether that came from maybe that person's dad's version of the HD gene or mom's version. And so suppose conceptually, if one had a fewer number of repeats, then that could help you try to select for embryos that have potentially lower risk. What do you think about that, Lauren?
Yeah, I guess that's hard. I mean, you could get like a reduced penetrance one, which we still treat it as a positive, but a more optimistic positive. So I think it's just what risk you're willing to take.
Okay, we'll move on to the next speaker. Thank you very much, Dr. Sue. That was excellent.
Thanks.
Our next speaker is Nikki Sims. Her topic is going to be the grant selection process, and she'll also assist with our 4th speaker in patient perspective. Nikki has over 15 years of experience in the healthcare and administration. She has over 5 years in fundraising a nonprofit. I can honestly say, after talking to Nikki, that she is very passionate about what she does, and we're very happy to have her. Nikki, it's all yours, and thank you again for participating.
Thank you guys for having me. And I want to piggyback off of the statement earlier. This is even for myself, every single time I go into something like this, I learn something new every single time. And it just great information that I can always give as feedback to our applicants as they apply and they come on board. So thank you guys. This has been great for us, and I can't wait to share it on our social media platforms for our applicants and those that follow us to be able to see and learn from as well. As many of you know, I am the Director of Grants and Clinic Relations for Help CureHD. Help CureHD is actually a nonprofit that is administered by athletes and causes. So whenever you see Help CureHD, you may see the ANC or Athletes and Causes logo as well, because Help CureHD is, it's an administered fund through Athletes and Causes. We were established in about 2017 by Joe and Allie Smith, Allie LaForce, to those I would say in the work field, in her personal life, Allie Smith. I'm going to see if I can. I wasn't going to do this before, but I'm going to try. And if this doesn't work out, then we're gonna back off. I'm going to see if I can get this to share some information that's just going to be. Let's see here. See if it's going to cooperate with me. One second. My apologies, guys. And let's see, can you guys see, and did it do it properly in this?
We're still seeing your face.
Okay, let's see.
No.
Hold on. Let's.
No slides. Are you trying to show slides?
I
Oh, now we see slides.
Yeah.
Nikki, you muted yourself as well. We see your slides, but now you're on mute. There we go.
And let's see. I have videos unmuted, but I can't see. I cannot see what you're saying. So I'm not sure what slide you're seeing because it's done something weird.
We're seeing a picture of Allie and the Help CureHD logos, and to find us on social media.
Okay, so I'm just gonna leave it there. It's not gonna, I want it to be able to go through those slides, but for some reason it's not allowing me to, can you see through those or no? Or it's okay, we're gonna leave it on that one slide. So as you all know, our foundation was started by Joe and Allie Smith back in 2017. When they initially started the foundation, they started and wanted to be supportive to the HD community more on the research side. And through their findings and trying to partner with different clinics and different research facilities, found that they wanted to make an immediate impact. And through their own journey in IVF, oh, can you guys hear me? Can you guys hear me?
Yes, we can hear you, and but your video was off, so now it's on again.
Okay, perfect. As I was stating, Joe and Allie decided that they wanted to be able to make an immediate impact within the community when it came to Huntington disease and IVF. And through their own journey, they were introduced to PGT and IVF through their current physician, which they're working with now, which is Dr. Roach at Heart Fertility in Houston, Texas. And they were introduced to PGT and IVF and really, really felt blessed and fortunate that they were able to do this, and really felt blessed and fortunate that they were able to financially be able to support themselves, support the process through IVF, but also realize how many families were not in their same shoes, how many families could not afford to possibly, go through the IVF process and spend the thousands of dollars to have it done. And then once you kind of put PGTM and PGTA into the process of it, then the additional cost that's added into it. So because of that, they had started Help CureHD and decided that they were going to kind of transition a little bit from more on the research side and help families fund their IVF journey to be able to have children so that they can make an immediate impact now on those families that thought that they'd never be able to have children. So what I really wanted to be able to talk to you guys about today is who we are, what we do, and how we are very, very passionate about helping the HD community be able to have children and eliminate the HD gene from, their family line forever. And as Dr. Sue stated before and Lauren stated before, it's a process. And when our applicants come on board, so many of them, I hear all types of stories. When a part of our application process, a lot of them, they give us information, detailed background on why they have chosen this journey. And you guys will hear from one of our grant recipients later, even those who thought they'd never have children. Whether it was they decided to have a vasectomy, or whether it was that they decided to have their tubes tied, or they just decided that they were not going to have children because they did not want to pass on the HD gene to their children. And when they hear about the grant program that we offer, I wish I could really put into words, honestly, the impact that I feel that we have on their lives, their current life and their future life, their future family, their future children within the process. So when we decided to do it, which is in 2017, we opened up our application process. And that very first year, we received 24 applicants. And out of those 24 applicants, we were fortunate enough that we were able to grant or award all 24. And, when I say that we award, I guess I should really talk to you guys about what that means. What does our grant include? What does it offer to the applicant? What's their responsibility? What's our responsibility in the process? And I think that as well is another one of those things that makes us a little bit unique from other grant foundations that are out there. Number one, we do only give grants at this current time to those applicants that are at risk for Huntington disease. So if you guys go to our website, which is www.helpcurehd.org, you will find our application on our website. Currently, it is something that you have to print, complete, and then you mail into us. Probably by the end of the year, it will be done all electronically, where you will be able to complete your application on file and then submit it. But as of right now, you do have to actually go to our website, print out the application, and then you're going to mail it in. A part of our application process, it's going to ask your general information. It's going to ask you information about your employment. It's going to ask you about your income. You will have to provide tax returns for the last 2 years. We do ask you to provide proof of your HD status. And that proof is not necessarily that you as the individual are at risk or that you carry the HD gene, but we do need to know that your mother or your father does carry the gene. I think because Joe, many of you may know his story, his mother Lee, who is a huge part of what we do every single day and why we do this. Joe's mom was diagnosed with Huntington disease in 2012. Unfortunately, she lost her battle to Huntington disease in August of 2020. I always say COVID year. And she has really been, the big inspiration for us behind doing this. It's how it all started. And because Joe is still actively playing baseball, he decided he didn't want to know his HD status. And I think a lot of you can really relate to this for multiple reasons, whether it be you're nervous or concerned about what it's going to mean for you when it comes to your life insurance, your employer. The biggest thing I think for most of the couples that I deal with is what it's going to do, I say, for your own individual psyche. How do you deal with that information? Once you find out, how do you deal with that? How do you feel? How do you continue moving forward? And because Joe is in that position and he's still actively playing, he doesn't want to know his status. We don't require the applicants, the husband or the wife or the male or the female, to say, hey, I know for a fact that I carry the HD gene, but you do have to prove that your mother or father does carry the HG gene, whether it be multiple ways. By death certificate, that means Huntington disease as their cause of death. You can also do it by providing their test results that shows their CAG repeats. You can provide us with medical records, whether it be from their, your primary care, their neurologist that you were seeing at the time. Medical records will also suffice as proof of their HD status that is required. We also do a criminal background check. You do have to complete. In the criminal background check, I have a lot of people ask me, what does that mean? Back in college, I got into an argument with a gentleman and we got into a fight and I got, I got an assault charge or I got a misdemeanor charge. Those little things that happened 20 or 30 years ago are not as big of a concern to us. Maybe we may take it into consideration if we see you have multiple charges, so it seems a little habitual. It may be taken into consideration, but those type of things, I don't want anyone to think that, hey, because something happened 20, 30 years ago, and I got to an argument with a guy at school or something like that, that it's going to keep you from being selected. Everything we do is reviewed on an individual basis. So there's no complete, there's not an exact recipe, I guess I should say, when it comes to those things. We do review each thing individually. So you do have to complete your background check. That's one of the things you do. The background check you can do online. That is something that you can click the link that's on our website and it will take you to the company that does our criminal background checks. There is a cost. It's the only thing within the application process that has a cost related to it. It is $8. You pay the $8 fee. You complete your background check and it sends us the results automatically. You don't have to do anything else with that. You are required to sign a release form. And with that release form, it allows us to be able to obtain medical records or ask specific questions in regards to your medical history, or say if we needed to confirm employment or we want to check your references. It's just you giving us authorization to be able to do those things. At no point in time do we ever tell anyone that the applicant is at risk for Huntington disease. We don't even say that we're calling from Help CureHD. We don't give any of that type of information because we do have those applicants that are non-disclosure. So we do not give any type of information that links or specifically states that you're doing anything that's affiliated or linked to Huntington disease. So please keep that in mind. I know a lot of applicants ask and are concerned about that, and we don't do that. Even when it comes down to insurance verifications, which we do have you provide insurance information to us. We do a very basic verification of insurance, but we mainly leave the bulk of that to the clinic. But we like to be able to provide that information to the clinic when we send the applicant information to the office. We like to be able to send them a complete, just a complete kind of overview of the patient between their information, their insurance information, so that they too can also know what's to be expected when the applicant comes over. So once you complete all of those things and you submit them into us, you are going to mail those into our corporate office, which is located in Thanota-Sassa, which is kind of, Thanota-Sassa is kind of like a suburban area in the outskirts of Tampa. So I always tell people it's in Tampa, Florida, but by mailing address, it's Thanota-Sassa. So we are located in Florida. You'll send that in. We do accept applications 2 different times annually. And for those of you that follow us, the twice annually is now really this will be our first time awarding twice annually. The very first year was in 2019 that we awarded towards the end of 2019, which we went into COVID year in 2020, which we did not award at all in 2020. And then those applicants that we did receive in 2020, they were awarded in 2021. So those years we only awarded twice. 2022 moving forward, we will have an application window from January 1st to March 1st. And then the grant application process will open up again from June 1st to August 1st. Once the application deadline closes, We will normally try to award within 30 to 60 days, depending upon the amount of applicants that we receive. Then we will award within that time frame. A lot of people also ask, well, how many people do you award per grant cycle or per year? There's no set number there. We award based upon our ability, the amount of funds that we raise per year is what really dictates the amount of applicants that we award, along with all of the information that's collected in the application, from their medical history to their personal information, to those things really determine how many people will be awarded. So there is no set number. First grant cycle, we had 24 applicants and we awarded all 24. Second grant cycle, we had about 82 applications that we received, and we were fortunate enough that we were able to award 54 couples to have the PGT-IVF our second grant cycle. We're getting prepared to award again now. We'll award again by the end of the month, and that number has not been released yet, but it will. I can say our goal is to always award as many couples as possible. I always tease and say if it was up to Allie, her heart would award everyone. And although it sounds great, sometimes unfortunately, we're just not able to, whether it be due to financial reasons or medical reasons that are linked or related to each couple. But we do award twice annually as of now. The other thing I wanted to really talk on with everyone is a lot of people also ask things like, will my income affect whether or not I am awarded? What if I make too little money? What if I make too much money? What if I'm, considered to be a mature age? What if I'm too young? Once again, everything is taken on an individual basis. And I could tell everyone, if you live in, some states, if you live in the state of Iowa and you make $150,000 a year, that might be a really good income. But if you make $150,000 and you live in the state of New York, it's not the same. Those are apples and oranges. So every applicant's information, we review it on an individual basis based upon where you may reside, your income, your employer. It's all taken into consideration. There is no simple kind of, I guess I should say, way that we do it that speaks the same for everyone. Everyone is reviewed individually when it comes to the application process. Another thing to keep into consideration while we do it is everyone always asks, well, what is my responsibility financially and what does the grant actually cover? As I stated to you guys earlier, unlike some of the other grant programs, we cover 100% of the cost for the IVF process. And when I say that, I mean from the day that you make your consultation appointment, costs are covered. A lot of times people think, oh, well, a cycle really begins once they start the retrieval process. We cover everything prior to that as well. So from the biopsies to your lab work, your consultation appointment, all of that is included in the cost of your IVF grant. The only time that a couple may see that they're responsible for any type of cost is we don't cover the cost of any testing, procedures, or medication that is needed when there is a true infertility issue. And what I mean by that is, let's say the gentleman, the male in the relationship needs to have a semen extraction. It's a separate test. That would be at the cost of the couple. Or if the female is determined to have DOR or diminished ovarian reserve, that is something, and they want to do specific medication in regards to that. And that's really something that can go for review. But something like that may possibly be at the expense of the applicant. Or we also don't do egg donation or sperm donation. It can be used in the IVF process. You can have it done. You speak with your doctor. You guys handle all of it. We, just for liability reasons, the grant will not cover or handle the cost or handling of sperm or egg donation at this point. It is something that could possibly change for us down the line, but as of right now, we do not. We also do not cover the cost of surrogacy. Once again, liability reasons why it's not something that's done. It is something that could possibly be done in the future, but as of right now, we do not cover the cost of surrogacy either. So those are things that we don't cover. We do cover, of course, PGT-M and PGT-A, as Lauren and Dr. Sue spoke to you guys earlier about what that means and what that is. We do cover the cost of both of those to be done. And we handle the cost from the retrieval to the transfer. Once your transfer is complete, that is when the responsibility, or what I say, when you go into your global OB care, that's when you will begin to pick up cost. 9 times out of 10, after you get your positive, once you find out, hey, you're pregnant, there will be some sonos and monitoring things that will be done where you will still see your IVF doctor, and it ranges, somewhere from 8 to 10 weeks. We also cover that cost. Once you're transferred from your IVF doctor to your OB, that's when you will begin taking on the cost of your pregnancy at that point, that we cover from the very, very beginning to the very end until you go into the care of your OB. So all of that will be covered by us. I'm trying to see if I want to make sure there's nothing else that I left out for you guys. If you go to our website, there's a lot more information there for you. You'll be able to find out a little bit more information about us and who we are. You'll be able to find our application that's there for you. You'll also be able to, on there is a link, is my phone number and my email address. So if you have specific questions or things that you want to ask, you can always go there and find it, and it will give you how to contact us, whether it be just because you are support of what we are doing, whether it be to help, whether it be to donate, whether it be to attend any of our fundraising events or galas. We welcome everyone to be able to attend. As we continue to grow, each and every grant cycle, we find that we receive more and more applicants. And it's great, because what ends up happening is that once we award one couple or one family in a specific area, they tell their family, they tell their aunt, they tell their cousin, they tell their grandparent, and it becomes word of mouth. And right now, even though I think what we do is great, you'd be surprised of how many people still don't know that we exist and what we do. And more than anything, we want to spread the news of what we're doing. Every single family that has Huntington disease, we want them to know that there is an option, that we are out there, and they can come and apply and allow us to help them have an HD-free family. We have 2 major fundraising events per year. One of them is normally in Newport Beach, and we do a second fundraising event that is handled, that we have in Houston, Texas, and starting in 2023, we will most likely do a 3rd fundraising event that will possibly be in Florida. We invite our applicants, our supporters, to come to 1, 2, or all of them. We appreciate the support. We ask for the support, because all the support that we get, all the funds that we raise, allows us to continue to help more and more and more families. On the other side of that coin, I want to just circle back and say that we could not do what we're doing right now without the support of our partnering clinics. Our goal has always been to have 2 clinics per state. I always say, unless you're in Texas or California, because those are very large, we could have multiples there. To have 2 clinics per state work with us or partner with us. And as our couples continue to come in per state, we would consistently send our couples to those same clinics. And we have some phenomenal clinics that work with us. Some of our clinics, they go over and beyond to support us and our applicants in making this process, or making this go smoothly and be successful, from multiple retrievals that they allow them to have, from multiple transfers that they allow them to have. I could not be more grateful grateful for those clinics that partner with us. So we work with some really great doctors. If you go to our website on our partnering page, you'll be able to find all the clinics per state that currently work with us. That site is updated on a daily, weekly basis as new clinics come on board. So we thank everyone who supports us currently now throughout this process. We thank those who are helping us now, those who are thinking of helping us in the future, because our goal in the end is to support those families who want to eliminate the HD gene from their family. I don't know if there's anyone out there who has any specific questions in regards to the grant program, who we are, what we do, but I'll go ahead and open it up so that if anyone does have any questions, that we can answer those now.
May I ask a question?
You absolutely can.
Hi, Nikki. I'm Susan Reynolds. I'm the chapter social worker with Huntington's Disease Society of America in San Diego and Orange counties. And thank you for the excellent presentation. It was really concise and also showed the depth of passion that Doug talked about. So just personally, thank you.
Thank you.
I have two questions. One is, if during the process, which is a lot more complicated even than I was aware of, that Dr. Sue explained, there are no viable embryos, can someone reapply for the grant in the future? And then the second question is, if there is an individual not married and has a larger supportive network, would they be considered, or is this couples only? Thank you.
Those are very good questions. So to answer the first question, once again, case by case scenario. So I'll give you a really good example. I just recently had a couple who did their retrieval, and none of the embryo made it through blast. So of course, the couple was devastated, of course, because, you know, when we do our onboarding with our couples, I try to answer and be resourceful to them. And, you know, and so many people always ask, you know, what to expect, and, you know, is this going to be hard? And they think that, you know, oh my goodness, you know, doing the injections, how's that going to be? And I always tend to tell the couples that, in my opinion, this is my opinion through doing this through the time that I have, that sometimes the mental can be way worse than the physical. The physical is something that your body's going to heal from. Your injection shots are going to go away. What they are not mainly prepared for is the mental part of it. And I say all of this because not having any embryo that make it through blast, or sending off 12 embryo to the genetics lab to come back and find that none of them are transferable, and your non-disclosure, they deal with so many different emotions. Oh my goodness, I must really have HD. 12 embryo were sent over, none of them were transferable. And as Lauren said before, it's one of the reasons why we offer PGT-A and PGT-M. Because if we didn't offer PGT-A, just like you said, we would be unconsciously giving them or telling them their fate sometimes. So when they go through the process, and say the couple that had no transfer, that none of their, the embryo made it through blast, one of the things that I always work with my clinics on is that I always try to advocate for them, for us to be able to do an additional retrieval if needed. So they don't necessarily have to reapply. The times that they find, if they go through the complete transfer and the transfer is not successful, then yes, they would have to reapply for the grant. But if they never go through the PGT-A, PGT-M testing, they only make it to the phase of the retrieval and nothing makes it through blast, we work with our clinic and we work with our couple to do another retrieval. We won't make them go through the application process again at that point. So, and then your second question, and I apologize, tell me your second question one more time.
Yes, thank you for that answer. And the second question is, if someone is a single person.
Yes. So we, in full transparency, we haven't had that scenario as of yet. So I do think there's nowhere in writing that says the couple has to be married. It doesn't say nowhere in writing that it has to be, you know, a husband and a wife or to people. It's not only couples. It's one of those things, once again, that will be done on a case-by-case scenario. So I guess I could say no. It is not a requirement that it has to be a couple that applies for the grant. They would just have to keep in mind, if they're using donor sperm or donor egg, that they can do that, but it will be done solely with their, between them and their clinic. We wouldn't cover the cost of it, nor would we at this point in time, for liability purposes, be able to be a part of that. And really, it's mainly more so the cost more than anything, but they could definitely do it.
Thank you.
You're welcome. Any
Thank
other
you.
questions from anyone?
Nikki, I just want to make a comment. I had no idea that you awarded that many grants. That is absolutely wonderful. If I was to
Yes.
guess, I would have said maybe a half a dozen, but you,
No.
as a person, yeah, you
Yes,
surpassed that.
54.
Yeah,
54 couples.
That's fantastic. I have a question as a provider. Is there a way I can refer someone to you, or would that help at all with the application process, or not so much?
Absolutely. Absolutely. We always take referrals. So that's one of the things with when we partner with our clinics, and even if it's not a partnering clinic, we absolutely take referrals. We want to spread the word. We want couples, individuals to know that we are a resource to them and that they can use it. So absolutely, if you have couples that come through, and as I'm sure you do it on a daily basis, absolutely refer them to us. The next grant cycle will open again on June 1st.
And that would basically just be reaching out via email. Is that preferred?
Absolutely.
Okay.
You can email me and then also send them to our website, so they could go ahead and print out the application and get that completed and sent in.
Okay.
Any other questions? And I apologize, Doug, I can't see the time because my screen.
We're at 11:36. I guess we'll go to our next speaker. Rachel, is she online?
Yeah, she logged in. Nikki, are you able to unshare your screen now?
I am. I apologize, guys. Give me 1 second. Let's see how I'm not even sure how
I might
it's literally,
I might be able to force you out. Let me see if I can do it.
okay. I've worked Zoom before. I'm not even sure what the screen is that I have on here.
There we go. Okay.
Hello.
Hi.
So,
How are you guys? I apologize ahead of time. I have a 1-year-old who decided that he did not want to take his nap today, so he's hanging out with us. So I am one of the original grants. I received one of the original grants. My dad was diagnosed with Huntington's when I was I think I was 18 when he was diagnosed. We didn't know we had it in the family, and it ended up being from my grandmother's side, and she had passed away from it, but we didn't know it until after. So I was tested when I was 22, and when I was positive, I did a lot of thinking about it and decided to have my tubes tied. I'm one of 6 kids, and of the 6 of us, 4 of us are positive. So, and I'm second oldest. So, I ended up having my tubes tied, even though I had wanted a giant family, just because it wasn't worth the risk to me to put that on a child. So that was long before I met my now husband, but my husband and I had talked about it, and he knew about my diagnosis, and we had decided, I'm a teacher and he works for the airline, and we had decided that either, we would just kind of take it as it came, and either we wouldn't have kids or we would adopt. And then I was on Facebook one day and happened to see the first round with the foundation, and they I filled out everything and put a note in there because honestly, I kind of expected it to be a 500 applicants kind of thing. And then I guess a month after, like they were supposed to have awarded, we got an email saying, hey, you can start. You were awarded, you can start. And I called my husband, was like, okay, so I think we just got this. I don't really know for sure. And that was in September. And then spoke with somebody. This was a few months before Nikki started, but spoke with somebody and then ended up, so we live in Dallas, and Dr. Roach, who is a doctor that they work with in Houston, was the one that did mine. And so we met with her the first time in October. And so we went from, we had the conversation in September of accepting that like we would start the adoption process. And then all of a sudden we got this news, and it was kind of like threw us for a complete loop because we had finally like 100% accepted it. And then we met with her in October, beginning of October, and then did the egg retrieval the week of Thanksgiving, and then ended up doing our first cycle. So I think we had 19 embryos. And then we came down to, we had 7 like transferable embryos. And my whole life, all I wanted was a little girl. And we had one little girl to transfer, and that one didn't end up taking. So we did it one other round, which was spring break. So March of 2020. So it was like the week that the world shut down. And I think we were one of the last transfers for Dr. Roach for a little bit. And he ended up taking, and we had our little boy, who is now almost 18 months and a terror, but worth it. And it's been healing for both of us because, my dad passed away from this really horrible disease, and I wasn't willing to watch anybody else I love do it. So I had really kind of cut that part of me and like closed it off into a box. And it very much was cathartic to have, to work through it with my husband, but also get such an amazing kid out of it. I teach 7-year-olds, and I have for 10 years. So to get to have one that was mine that I got to keep was pretty awesome. And we have had it. He has by no far been easy, no way been easy, but it is worth every single second of it. It is worth every single shot that I had to take. It is worth every single drive at 4 a.m. that I did to Houston. It's like a 4-hour drive for me. And worth every single one of them, worth every single grape that he is right now dropping on the floor. So my decision is different from the rest of my family. I have one sister who decided not to have kids at all, and I have a brother who they're currently actually pregnant with their first and just decided to have one. And everybody makes their own decision and does it their own way. For me and my personality, I very much wanted to know the moment that I knew I might have it, I went and got tested, just because for me, peace of mind, I could plan for the future. And I'm currently 36, so I've known for a decade and a half or so. And, now it's kind of just become part of my story, but because of Jack and because of having him, it's become a positive part of my story almost because of the foundation, it's a positive, Huntington's has brought about this positive little thing over here next to me who I know will never have to fight this, and I'll know, it's just a complete relief for me and for my husband both to know that he'll never have to worry about it the way that I do. So anybody, if you have any questions, feel free to ask.
It sounds like you had a relatively, I don't want to say easy, but easier experience. What would you say to women who are doing this, who may have gone in and been told over and over again that they don't have viable embryos?
Good question. So let me say, I have a friend who was doing IVF. She doesn't have the Huntington's bit, but she was doing IVF the same time I was, and she did 9 rounds of IVF, and she's a teacher also. And it was horrible, the amount of shots and the amount of, grief that you go through. But she now, after 9 rounds, has her second baby, and talking to her the other day, said every single moment was worth it. And it was worth it for her. Also, I think what we are planning on doing, we might have one more in the future, but we still have 5 embryos, viable embryos. And I think we're going to put those up for embryonic adoption for people who can't get embryos, just as because it has all the genetic testing done, and so there's nothing abnormal about them. So I would also say 100% that's how we would have done it if we were trying and couldn't.
Can I ask you, do you have any physical ramifications from going through all of the hormone therapy? And
so my husband probably would say yes. My hormones would try to kill. I probably tried to kill him a few times. It was, when I first did the egg retrieval was probably the hardest, just because I felt like, because I had so many follicles that were growing in size, I genuinely felt pregnant at that point, and it was very uncomfortable. But up to the egg retrieval, those shots were nothing. It was no big deal. The hardest part, pain wise, would probably be doing, because you have to do the shots after you're pregnant to keep your body telling your body you're pregnant. And those are no fun. Those are not any fun at all. But you kind of get into a rhythm, and I don't know, I dealt with it, because by that point I knew I already had the baby growing. So that also made it a lot more worth it. As he yells at me.
yes. Well, since you've had the children, there was one woman I talked to that had done this, and she says that now, since she's had her, and she had twins, since she's had her babies, that when she ovulates, it's very painful, and she blames that onto the hormone shot she took for the IVF. Have you had that experience?
So I have endometriosis also, which I didn't know until I actually did IVF. She found it. So I'd always had more painful periods and ovulation. I always knew when I was ovulating. My very first ovulation was fairly painful, but after that, once my body started to regulate again, no ma'am, it seems to actually be a little bit better for me.
Oh, good.
So yeah.
I have another question. Do we get to meet your son? You want to put him on screen?
Oh, sure. Come here, child. Oh. So this is Jack. Can you say
Jack. Hi.
Hey, so cute. Hi.
He has been eating a pear, so it's all over him.
Yeah.
But
Hi, Jack.
can you say hi?
Hi.
See, now This is the fruits of your labor. Literally, this is what you guys did this.
Yes.
I know.
Yep. We went to the gala in Houston this last year, which was interesting. Although now I don't think he would sit still long enough to do that, would you? Yeah. He's very used to the world, revolving around him at this point.
Yeah.
So,
Hi.
say hi.
Hi. So cute.
Oh, anyway, so yeah, that's our story.
Thank you for sharing your story.
Thank you.
Absolutely.
Thank you,
Absolutely.
Rachel. Thank you, Jack.
Thanks. Say bye. Can you say bye? Say bye. No kisses.
Bye. Bye. Thanks, Rachel.
Yes,
Thanks,
ma'am.
Rachel.
Yes, sir.
Any other questions?
I have a quick question that might be more for Nikki, but just hearing, driving 4 hours to Houston, I'm wondering how often, are you trying to enroll additional clinics or partners? Does that get generated by a patient request or?
Yeah, so a lot of times, for example, this current grant cycle, although we may have, say, 2 clinics in an area, specifically, I have a couple right now who is in Sacramento, and getting a clinic there for them has been a little bit more of a challenge. And so they can very easily, drive and do, but, closest clinic to them for us is going to be if they're willing to drive to, to Orange County. And so yes, we do. So when the application process starts and our applicants come in, it's a phase process. So we have a beginning phase, a middle phase. And when we know that an applicant could possibly be awarded, we specifically look at where clinics are in their area. If we don't have a clinic that we're partnered with at that time, my work begins. So I immediately get into the process of trying to find a clinic that's willing to partner with us in that area. For several different reasons, but we do continuously add on clinics, especially if we have a couple that comes on board and we're not partnered with anyone there already. So yes. Anything else?
Thank you so much, Nikki, for getting Rachel on board too at the last minute. That was wonderful
Absolutely.
seeing her perspective.
Yes, thank you so much. I love kind of having our applicants be able to share their experience and their journey, because like anything, it's through you guys and a lot of the support groups, it makes it a lot easier when they can ask those questions and, kind of be the human form of what to expect. So I love being able to have them to be a resource to our applicants. We always try to, we try to piggyback off of and allow our couples to use prior couples as resources for themselves as they're going through the process.
I have one question. Generally, what is the overall cost? How much does it cost to put someone through the process?
It varies per clinic. It varies per clinic. One of the great things about our partnering clinics is that a lot of them, some of them may give us discounted rates for services. So some of them work with us in different ways. It may not be discounted rates. It may be something simple as their willingness to do additional retrieval for a couple. So we work with each of our clinics in different ways, but on an average, I can have a clinic that can charge us anywhere, say from $8,000 or $9,000, which is very inexpensive for an IVF, but it could be upwards to $30,000. And that, and I think a lot of people, and when I say, $8,000, that's just on the clinic side. That's not including the PGT-M or PGT-A testing. We cover the medications. That's another thing I apologize I didn't mention as well, is that not only do we cover the cost of, the retrieval, the transfer, all of the, all of the diagnostic testing, everything prior, the PGTA, the PGT, and we also cover their medications. So all medications throughout their IVF, the IVF process, we cover the cost of that as well. We currently partner with S&P Pharmacy. We utilize them quite a bit, or there are times that the patient's insurance will dictate what fertility pharmacy that we use, whether it be Freedom or Village. We kind of go off of what their insurance dictates to be used if they have insurance coverage.
Excellent. Well, that brings us to just about the end of our program. I want to thank all the speakers and all the participants for coming and listening. I know once the word gets out, there's going to be a lot more people reviewing this video. Thanks so much. You're definitely, what you do is definitely a positive aspect of in helping Huntington's families. So thank you. And thank the Allie and Joe Smith also.
Thank you guys for having us.
Okay, well, we'll have our next Education Day in August. We wish everyone the best, and thanks again for viewing.
Thank you guys so much. Everyone take care.
Bye-bye.
Thank you.
Bye-bye.